We're going to talk about a relatively rare situation, although it occurs, as you all know. Are all of you clinicians? Is any one of you only a biologist, a scientist? No? All clinicians. Perfect. Okay, so how to treat relapsed AML? Well, in some cases I know, in many I don't. But let's talk about it. Conflicts of interest? Not really, I guess. I work in the Prinses Maxima Center now, although I'm still professor at Amsterdam University Medical Centers, because the Prinses Maxima Center is not an academic institution, although it works like it is. We have centralized the care for Dutch children in one center, being lucky, I guess, to have a relatively small country with a good infrastructure. Our insurance system allowed it, and that led to a hospital that is dedicated to children with cancer, with only 85 hospital beds, but in addition 35 daycare beds. We have now about 1,500 employees, of which a third is scientists. This is a relatively small center, so we really need our neighbors. And that is the University Medical Center Utrecht with the Children's Hospital, which is called Wilhelmina Children's Hospital. And we need a shared care model, because it's not, of course, necessary for each, checkup or blood transfusion or follow-up to go to a centralized center. So we do that in hospitals closer to home, and that is at the end 15 hospitals spread over the country. And we see 600 newly diagnosed children with cancer per year, so that's about 20 AMLs. So we have sort of a handful of relapsed AML every year in our center. What I want to talk about, simply how frequently does it occur, and I also will talk a little bit on refractory AML, prognostic factors, appropriate treatment, and developments that we are seeing, including some innovative treatment. So events in pediatric AML. Early death, arbitrarily defined as within 42 days from diagnosis, occurs in a few percent of children. It can go up to 5%. We have seen more recently in 2 or 3% of the children this happening. It still occurs. It goes down with appropriate diagnostics, immediate start of treatment, and good supportive care. You can decrease it to below 5%. Refractory disease, the same, but it still occurs in a few percent of patients. But relapse is the most frequent event, let's say in about a quarter to a third of our patients, partly depending on the intensity of your upfront treatment. And then death in complete remission, up to 5% again, also related to how often you do a transplant, because I think the treatment-related mortality if you do transplantation is a little bit higher than when you do chemotherapy only. So refractory relapse AML at the end is about a third of our children with AML, so that's not so rare anymore. Well, I'm not going, of course, through this, but if you want to look at the literature out there, these are the major studies with a larger group of children, relatively non-selected, and that is goes up to a recent publication by the Japanese group. And if you see from up to lower, I'm not sure if you see this. No. But in the more recent years, you see that the survival rate goes up to 40% or so. So that is really encouraging in a way. So what are known risk factors? I think we know already for quite a long time that time to relapse is a very important factor, and the later the better. And you sometimes wonder whether a very late relapse, perhaps in reality, is a new AML arising from the same pre-leukemic clone. But the later the better. Cytogenetics, I think we already know from a long time ago that core binding factor AML is better when you relapse. And having FLT3 ITD is worse. If you were initially lower risk, you still do better when you relapse. And if you have not seen a transplant before, you do better as well, because, of course, as you probably all know, at a relapsed AML, you typically go for a transplant. Out of the studies that I showed you, there's only one study that was randomized, and I have led that trial. So I'll show you a couple of slides on that trial we called Relapse AML 2001-01. And we looked at a couple of factors: early treatment response, the treatment itself, and we could look into somewhat more detail into the cytogenetics, although we did not have much data on molecular genetics, unfortunately. So this is how the trial looked like. It was a relatively simple design. There was a randomization up front. I don't think the pointer is working that well. Do you have another pointer or not? Sorry? Do you have another pointer or not? No? Okay. It doesn't work. Hardly. So there's a randomization up front. I hope you can see it. Between FLEC, at that time we still used GCSF together with FLA. I think we skipped it now, so we can talk about that if you want later on. So now typically it's FLA, but at that time we used GCSF in addition to FLA, and it was randomized against FLA plus liposomal daunorubicin. That drug unfortunately disappeared from the market, unfortunately because it seemed to be a less toxic drug and quite effective. So it's more or less yes or not giving anthracyclines in reinduction course 1. And then the second course was simply FLAG again. If you achieved remission, you went on to a transplant. And sometimes you need more time to find the donor, so we had guidelines on bridging chemotherapy. If you did not achieve complete remission after 2 courses, you were off study. Overall survival looked like this. So certainly this was a very large international trial, including countries from all over the world, including Argentina, for instance. And 38% at that time was really encouraging. I do want to point out that you also see some late events. So even after a couple of years, we saw sometimes a relapse and sometimes a treatment-related mortality. This early treatment response turned out to be, together with the time to relapse, a very important prognostic factor. And perhaps somewhat to our surprise, is that the early relapses, and that is within 1 year from initial diagnosis, the early relapses, a number of them still had a good early treatment response, and that's the green line. They really didn't do that bad. So that's interesting. Huh? So that's perhaps the children that really benefit from a reasonable reinduction or a good reinduction and then a transplant. But an early relapsed AML certainly still can be cured. This was not published, so this is unpublished data, but I'll show you another slide later on. And this is about when you have had a transplant in CR1 already. Does that significantly impact outcome? It does, but it doesn't mean that a second transplant is not possible and that when you get a second transplant after reinduction chemo, you cannot be cured. This is within late relapses only. And you see that the red line, these are the children that had a second transplant after they relapsed, and they still had a reasonable chance of cure. So this is being done more and more often. Last year we published, after some time, a more detailed analysis on cytogenetics. And actually it looked as if you had core binding factor AML at relapse, it was favorable and the rest was relatively poor, with one exception, but I think that might be by chance. And these were the children with the translocation 6-9. So they are over here. Translocation 6-9. They did relatively well, but look at the curve, it's a very small group. So I think that could have been by coincidence. Because typically translocation 6-9, we consider that as a poor factor. So core binding factor AML is relatively good. And it is not surprising, perhaps because these are children that benefit from a transplant. We also know that from initial diagnosis and treatment, right? The core binding factors AML, they do benefit from a transplant, also if you do it in CR1. Of course, you don't need it to cure the majority, so then we only give chemotherapy. but they do benefit from transplantation. So probably the graft versus leukemia effect in these children is better. So what about the influence of treatment? Well, there was an impact. The main endpoint was the early treatment response because of lack of power to demonstrate significantly better survival. And at the main endpoint, which was this day 28 bone marrow, arbitrarily defined as a poor response if you had more than 20% blast, so really refractory disease, and good if you had below. The response rate was better if you added an anthracycline to the flag. Perhaps not a surprise, but it was never demonstrated. And it improved by about 10%. And also the CR2 rate, so the second CR rate, improved by 10% if you added liposomal daunorubicin to flag. And this was of borderline statistical significance. And we saw it in both groups, early and late relapses. So also if you had an early relapse, you still benefited from more intensified reinduction chemotherapy. And remember this because later on I give some recommendations on how to treat relapsed AML, and this is one, I think, of the take-home messages. Overall survival was only a little bit better, and I guess, well, far from statistically significant, as you can see from the p-value, with danoxome added to flag. And if you think about that, how would that be explained? I thought the explanation is that there was still a relatively high burden, a high measurable residual disease, but we didn't measure it at that time. But I think even though the CR rates were higher, the children with CR still had quite a lot of MRD, and that's when they relapse. So if you would do a better consolidation, for instance, I think the overall survival could have gone up further. But we had more relapses in the children that had flag danoxome, right? And my assumption is that is because of higher MRD levels in these children. If you want to read it, it's 10 years ago that we published this. Core binding factor AML, that was the subgroup that clearly benefited, also in terms of survival, from adding danoxome to flag. And a quite remarkably high survival rate, right, from relapse, including the early relapses. So what is ongoing? Well, after this trial, we prepared another relapsed AML trial at the end that failed, but we had in the meantime sort of a registry in the International BFM Study Group setting, and that was simply the same treatment as before. So danoxome flag, followed by flag, and then a transplant. And what is interesting is that with the same treatment, although some children had a different second reinduction course, but with more or less the same treatment, survival improved. So I think this is better supportive care and probably better transplants. I mean, better conditioning, less treatment-related mortality, etc. So in this registry, a more recent cohort, the survival was significantly better than in the relapsed AML 2001 trial, as you can see in this picture. On the left is for disease-free survival, and on the right is for overall survival. Refractory AML, what does that mean? Well, you can still be cured. That's also, I think, a very important lesson. So even if you don't respond to the first course of reinduction chemo, it's not a hopeless situation at all. You can still be cured. And this is the slide I mentioned. So this is a second sort of analysis in a broader range of children about the children that had a second transplantation after having had a transplant in CR1. And certainly in the more recent cohort, survival up to 40% or so. Some other papers or efforts from groups all over the world. This is from a French group. Actually, the schedule they used is the schedule we wanted to investigate in relapsed AML 2010-01, but for many reasons that study failed. And what they did is they used the best arm from relapsed AML 2001, and that is FLAG with an anthracycline, and they added myeloid for a single dose at 4.5 milligram per meter squared. It's an interesting discussion. What is the optimal dose of myeloid? I don't think at the moment we know. The MouthChat study will give us some insights, although it may also depend on the burden of AML when you give myeloid and what the dose should be. But they did this regimen in 29 children and had quite encouraging results. On the top is survival, on the lower curve is event-free survival. So overall survival close to 50%, but in a small group of children, of course. The COG, and this is data that Todd and Andy provided, they did the study with CPX, so the liposomal formulation of the combination of daunorubicin and cytarabine, followed by FLAG in a small subset of children, but children that had quite many treatments before, so it was not only first relapse AML. And sort of the cumulative CR rate was about 80%, and overall survival after 2 years, 50%. And what often is done in the US now is giving FLA and myeloid, but they don't have an open trial for the bulk of the first relapsed AML children, which is unfortunately the case in most countries, which is, I really think, a pity. So I hope someone in the audience will take the initiative to do a relapsed AML trial. St. Jude, they are doing trials, certainly, and they investigated venetoclax. That is a very interesting drug, a BCL2 inhibitor. And they combined it with cytarabine, initially lower dose, then higher dose, and then they added daunorubicin for 1 dose, and that was safe. And Carroll reported a couple of years ago that overall CR rate was 70%, certainly encouraging. And there's now a PEDAL trial that many centers participate in, but that's in second relapsed AML and in refractory first relapsed AML, and some children have first relapsed AML, and for a couple of reasons, mainly cardiac dysfunction, are not supposed to be eligible for more anthracyclines, and then they are eligible for this trial, where they get FLA, myeloid plus or minus in a randomized way venetoclax. I think that's a very interesting study. Although I would argue we should do that in first relapsed AML. If you would study nowadays prednisone in third relapsed ALL, we might conclude the drug is not effective, won't we? So you really have to think about that. If you investigate new drugs in a too late setting, they may not work, while they might be very effective upfront. Brenda told me about the UK setting at the moment. There's no formal trial. Typically, FLA or IDA-FLA is giving. They use, on a compassionate use basis, FLT3 inhibitors in case of a FLT3 ITD. And, of course, do a transplant in CR2. There's interest in CPX 351, but I'm not sure if the company is so much interested in doing more pediatric trials. In Japan, also no formal trial, typically FLAG plus an anthracycline, followed by FLA and then transplant. Perhaps I should say a little bit about the GCSF. So we saw a couple of children when we started with GCSF before giving the chemotherapy, because it's a chemosensitizer, essentially. We saw a couple of children with pulmonary complications. Actually, of course, GCSF induces proliferation. And in some of these kids, there's also a lot of leukemia in your lungs, and they developed ARDS. So we decided not to use it, also because there was an adult trial comparing FLA plus FLA and GCSF and not showing a benefit. Okay, the Japanese are considering to join PEDAL 2020D, which is the venetoclax trial. The consortium, I will talk a little bit about that later, that I'm now working in with the Dutch group, is the NOPO-DB SHIP consortium. We also don't have a formal trial as a group. Some centers collaborate in early phase clinical trials in the context of PEDAL, including this venetoclax trial. And we have some common recommendations, but there's no consensus and there's no formal trial. But it can be FLA, daunorubicin, or FLA-mitoxantrone, FLA-mylotarg. There's this combination clovarabine, cytarabine, daunorubicin, or published by the Italians, clovarabine etoposide, cyclophosphamide, Vyxeos. Well, couple of possibilities. I guess we don't really know what is better. There are some unusual options I always like to mention. I think Jonas Abrahamsson typically recommends MACE. That is an old course. Well, it's a course from an old MRC trial with emsacrine. And I think what is still interesting to keep in mind is the combination of high-dose methotrexate with asparaginase. So Jude published on that. And there's some evidence that especially erwinase is more effective in AML, and if you combine it with high-dose methotrexate. So in some of these children, you can think about it, because it's typically available, of course. There was this ITCC study published by a Dutch colleague on this clovarabine, cytarabine, liposomal daunorubicin. Well, at the end, it all looks a little bit the same. This is more recent, relatively short follow-up, overall survival 60%. Yeah, you could say that's better, but I think the group is small and the follow-up was not so long. So if you think yourself when you have a child with relapsed AML, what do you need to know? And when I was sitting and thinking, what do I want to know? This is what I came up with. So I challenge you, what did I forget? Did I forget anything? Is there something which is not on the list? That could well be. Like I said, no coffee. Is there anything that you would really want to know that I forgot? Correct me, and then I'll add it for the next presentation somewhere. This is probably typically it, right? But what did the child have initially? Time to relapse. Although at the end I will show you, but it will not all have an impact on what you will do in terms of treatment. But you do need a new workup on the biology, because we have seen many papers now that biology can change from initial diagnosis to relapse. We could talk about whether that's clonal evolution or clonal selection or something else. Could be, like I said, it's a totally new AML and not a relapse. That's, I think, sometimes happening. But you must do the workup again. Of course, look nowadays for treatment targets. I think you should know whether there is CNS involvement. You want to know the organ function, especially of the heart, but not limited to that, of course. And of course, you have to look what is available. I know that not in all countries everything is available. Well, what would I recommend? Well, I think with that relapse trial in mind, that was the only randomized trial, I would say that you should not give only FLA, if I look at these data. But that's being relatively optimistic, because I know that long-term survival was not for the majority of children better when anthracycline was added to FLA. But I think nowadays we have better consolidation, we have better transplants. So if the child would tolerate it, I would give FLA plus something. And I mentioned daunorubicin because we all know it, it's typically available. I don't think we have ever seen data whether daunorubicin is better or worse, or mitoxantrone is better or worse in this setting. We have been using mitoxantrone a lot, and we are quite happy with it in our consortium. But I don't think we have, in a relapsed AML setting, ever showed that it's better. In initial AML, I would argue there is now some evidence that mitoxantrone is better than, for instance, daunorubicin. But, well, that's a different topic. I think there's quite a lot of data out there that Mylotarg is effective, and if the child has not seen Mylotarg at initial treatment, I would argue it would be a good idea to give Mylotarg. Of course, if the children are have AML cells that are CD33 positive, a few percent of AMLs do not express CD33, and that's a relatively simple marker to predict efficacy of Mylotarg. That is data mainly from the COG. If you have core binding factor AML, I think you really must give either an anthracycline or Mylotarg or both, because that was in the randomized trial clearly the subset that benefited from an anthracycline, and there's also data on that with using Mylotarg. If you have a FLT3 aberration, add an inhibitor. I think I will show you in a minute. In initial AML, we tend to focus on the ITDs, but when it's about it being a treatment target, the tyrosine kinase domain mutations are also good targets. So when you have relapsed AML, you may want to use an inhibitor. I would recommend that. And you can, I think we have now data on the safety of combining inhibitors, such as FLT3 inhibitors with chemotherapy. Of course, you have to worry about cardiac dysfunction. We know that when the cumulative exposure to anthracyclines goes up, there's a higher risk of late cardiotoxicity. We are, for that reason, now using cardioxane, and there's now also sort of consensus statements that in the setting of pediatric AML, it's recommended to use it. There is a concern for secondary malignancies, MDS. If that is true, it's a very, very small percentage of children developing it, and the protection on the cardiac function is probably more important. Would Vyxeos help because it's liposomal, so you have a sort of a different exposure to the cardiac muscles? We don't know, simply, perhaps. Anyway, you go to transplant, and typically after 2 courses, there's one paper in a relatively small group of children, I think from the Australia-New Zealand group, that looked at the number of courses at reinduction in relation to outcome before transplant. And the conclusion was 2 courses is the best. 1 course was not enough, 3 courses might be too much. I guess this is also related to the MRD levels going into the transplant. So ideally, you look at these levels to guide you to decide when to do the transplant. Not always possible. But we know so many things we do not know, right? Like I said, number of reinduction courses. In general, 2 seems to be the best, but it might be dictated by MRD monitoring, which is hardly done at the moment. Type of chemotherapy, use of novel agents. CNS prophylaxis at relapse, what should we do? I would recommend triple intrathecals. We give ALL patients so many intrathecals, why not give our AML patients a couple of them? Of course, I'm not a transplanter, by the way, my disclaimer, but the donor, what is the best donor? What is the best conditioning regimen? And then we are seeing some maintenance treatment post-transplant in specific subgroups. I'm not a fan of chemotherapy maintenance treatment. There's 2 trials showing it's a disadvantage in general in newly diagnosed AML. So I'm really not in favor of maintenance with chemo. But with the novel targeted agents, it might be a different setting. And I will show you a little bit on FLT3 inhibitors. And that really seems to be quite a different setting. So a little bit about innovations, new drugs. There's many reviews on this. I thought it's a nice one from Jeff Rupnitz and his group from St. Jude's. And of course, there's many possibilities nowadays. It's really, in a way, too much for our population. But of course, fortunately, the adults are also exploring most of these. But I would want to draw your attention to the menin inhibitors. They might be especially effective in children with a KMT2A rearrangement and with a NUP98 rearrangement. That's quite interesting at the moment. The FLT3 inhibitors, I think, is quite important. Venetoclax, the BCL2 inhibitor, Mylotarg, Macrolizumab is coming up and seems to be an interesting drug. And of course, we have BiTEs in this field as well, although not as successful as blinatumomab so far, but certainly some interesting products. And of course, CAR T cells. But for a number of reasons, CAR T cells in AML have not been that successful at all so far. But who knows? That will come. A little bit on FLT3 inhibitors. So the COG have studied sorafenib and are now exploring gilteritinib. To the best of my knowledge, BFM and IOP are still studying midostaurin. And our consortium, NOPO-DB-SHIP, we will study quizartinib. So a little bit on quizartinib. It's a highly potent and selective FLT3 inhibitor. It's what they call a second generation inhibitor, although I don't think that makes it much better than the first generation drugs. But it's certainly quite effective for FLT3 ITDs. Be careful, it does not target the tyrosine kinase domain mutations. So a child with a TKD mutation, you should not give them quizartinib. Then consider, for instance, gilteritinib. So if you look at the text, the FDA approved a couple of FLT3 inhibitors now. Midostaurin has been approved. That was the first one. They improved gilteritinib, and quizartinib is now under investigation. The file has been submitted, but quizartinib has not a formal approval yet. But that's likely to come because this was a trial that was, well, in a way quite similar to the midostaurin trial. They called it the Quantum first trial in adults with AML. And it's giving quizartinib in addition to chemotherapy during induction and consolidation and after transplant, what they not call maintenance but continuation treatment. And this was a trial done in more than 500 adults. And why I think it's likely that it will be approved by FDA is because it showed a more or less similar benefit, perhaps a little bit stronger benefit. You could argue it's a modest benefit. If you look at the curves, of course, the difference is modest, but there is a significant survival benefit when you add quizartinib to chemotherapy. Was it studied already in children, this drug? Yes, it was. Already, in fact, a long time ago. Todd Cooper published that data some 7 years ago. And it was a relatively small study done in a sort of early clinical trial consortium in the US called TACL. And what they reported is that the quizartinib was more effective if you had an AML with an ITD. If you look at the number of children, of course, relatively small, 17, but the responses, CRs, they were typically seen in the children with the FLT3 ITD. And that is perhaps better illustrated by this figure. This is before and after exposure to quizartinib, looking at the bone marrow blast percentage on the vertical axis. On the left for the ITDs, on the right for the wild type patients, either AML or ALL, and you see that when you have a FLT3 ITD, you rapidly clear leukemic cells from the bone marrow, which is rarely happening when you do not have an ITD. There's this one interesting patient that did respond to quizartinib that was not having an ITD. So interesting case, but if you have an ITD, you are more likely to respond. So there's an ongoing trial in Europe looking at quizartinib in relapse or refractory pediatric AML. They must have a FLT3 ITD. It's slowly enrolling because, of course, you know, the numbers are small anyway. The ITDs is 10%, and with the current treatment, overall outcome of AML with FLT3 ITDs is certainly not that poor anymore. Relapse rate is about 30-35%. So it's not easy to accrue children, but the trial is open and enrolling. Some other issues in relapsed and refractory AML, I already mentioned. So you have to do the biological characterization again, because there's this phenomena of clonal selection and clonal evolution. So at relapsed AML, it certainly can be a different biological picture than at initial diagnosis. What is also interesting is this change towards detecting relapses earlier. And we are struggling, I think, nowadays with definition of molecular relapse and when to treat. As we speak, we are treating in my center a child that formally, according to our own definitions, does not have a molecular relapse. But we thought everything sort of pointed to he having a molecular relapse. But we will see more relapses, like in APL, that do not have frank disease. We detect them early, and we might give them a better chance of survival if we treat them at that earlier stage. Although that has been proven in APL, I don't think it has been proven in relapsed AML in general yet. But it seems to make sense, of course. I do have one worry, and that is that you go to transplant too early, and that you end up going into transplant with more MRD levels than if you would have given the regular chemotherapy. And, well, probably going into transplant with more MRD levels gives you a worse chance of survival. Well, second line of treatment, so there's, of course, concerns for toxicity. So certainly cardiotoxicity is a concern. And finally, what about second relapses and refractory first relapses? What's in that setting? Well, there's a little bit of literature on that in children. Two recent papers, one from the BFM group, published in Cancers, and one from the Dutch group. But that study was done in the NOPO-DB SHIP consortium, published last year. And I think what it shows that even a second relapse AML, you still have a chance of survival. And the curves are like this. Of course, this is a selection of children, right? Because many children don't end up being treated. But if you get treatment, you still have a chance of survival. And the same sort of risk factors apply. So if you have a late second relapse, it's better than have an early second relapse. If you do not have FLT3 ITD, it's better than when you do have ITD, etc. Well, typically these children are being treated with novel agents, of course. Well, I think the best sort of, in a way, approach to relapsed AML is to avoid it. It's interesting, sometimes I also had a discussion with a colleague yesterday, and so there was this reasoning to keep good drugs out of the first line of treatment so that you use it later on when they relapse. I would argue that you don't want relapses, so I would use the best drug at initial diagnosis. So that's what we are trying to do in this consortium, NOPO-DB SHIP. I will show you some data with permission from Jonas Abrahamsson, who is the PI of the current trial. It's still enrolling, close to be closed. That's what we call NOPO-DBH AML 2012. This is event-free survival, so careful, this is initial AML. Event-free survival went up to just above 60%, that's really an improvement. Overall survival is close to 80%. Other groups are showing the same, excellent overall survival. It does matter whether you have standard risk, high risk, or refractory disease. But I would argue again, and you have seen the other slides, the chance of cure if you have refractory disease initially is still quite high, I would think. I mean, it's not what you want it to be at 100%, but it's still high enough to justify continued attempts to achieve a remission and to do a transplant. And I don't have time to sort of explain what the potential factors are that led to these curves, but we have a significantly lower relapse rate in our AML 2012 trial, much lower than in the previous trial. That was 40%. So these data and some other data, and of course data from literature, led to this study design, and this is how we want to do the study. It has not been approved as it is depicted here yet, but what we want to do is we want to do, avoiding relapses, to do a randomization between MEC, which in our hands is the best induction course 1, versus MEC plus Mylotarg. You may argue, well, the COG published a benefit of Mylotarg. In adults it was shown. Why do you want to randomize for it? Why not simply use it? Well, of course, an impact of anything in treatment is always also depending on the backbone of your treatment and its success. What I mean is, if your backbone cures 100% of the children, nothing that you add will give a higher survival rate. Nothing, right? Because it's already 100%. So we thought with our backbone having now event-free survival rates of above 60%, it was necessary to demonstrate in a randomized trial that Mylotarg benefits these children. It's costly, it has side effects. So we wanted to prove that. That's why we do this randomization. If the children have a FLT3 ITD without a concurrent NPM1 mutation, they are eligible to go into a quizartinib trial, a linked trial as we call it. This was set up as a sort of complex clinical trials set up with a master protocol and then linked trials. So the quizartinib is explored in a linked trial. We do a bone marrow just before giving the second course of chemo. And that is important because if it shows a high percentage of leukemic cells, you are high risk. But we also do an earlier bone marrow, we call it the day 22 bone marrow, to see whether there's 5% or more of leukemic cells. And if that is the case, we give the second course of induction chemo as soon as possible, meaning when the child clinically tolerates it, and we don't bother about the peripheral blood regeneration. And with that approach, we have shown in the past, published already, we have really improved outcome for these children. So the second course is quite conventional, ADE. We randomized in AML 2012 ADE with FLA-D. I thought that would be better, but it was not. So we simply use ADE. And then, of course, you have to document complete remission. If you are standard risk, and that also implies achieved complete remission, you are eligible for the second randomization. And that is a non-inferiority trial. And we want to prove that you can omit one course of chemotherapy safely for the standard risk patients. And it's, I think, very important what course you omit. And we decided to omit, as you see, the high-dose cytarabine etoposide course. And arguing that using one more course with anthracyclines, in this case mitoxantrone, will benefit the children and also makes it unnecessary to give a third consolidation course. So the children that have the FLT3 ITD, they will continue to have quizartinib added to chemotherapy, and after the transplant, because they are still all getting a transplant, they will get quizartinib unless if you had achieved MRD negativity after course 1 and remained to be MRD negative. These children, it's a small subset, but these children do quite well already today. So we thought it is not justified to expose them to 6 months of quizartinib. But all the other children, the majority, they will get quizartinib post-transplant. And then this is still being negotiated with the company AbbVie, but they are busy with other trials. But we hope that we can use venetoclax for the other high-risk children added to HAM before going to transplant. And of course, the assumption is that with venetoclax as a sort of a chemosensitizer, you go into the transplant with a less leukemic burden and you have a better outcome. And we will have some recommendations on salvage chemotherapy when you are having refractory disease. So in conclusion, and then we have some time for questions and discussion. In conclusion, the outcome is dismal. It's still below 50% survival. And I think it's in a way disappointing that there is a very limited number of open trials for the bulk of patients, or perhaps there's no trial at the moment. We do need a better reinduction schedule because CR rates are 70 up to 80%, but you want to have, of course, 90 or 95% at least. We need better consolidation because the probability of overall survival on the long term is 50% at best. Certainly encouraging, right? It's not as low as you might have thought, but we want to go to 100%. Recharacterize the biology because it might have changed. I would say give FLA plus an anthracycline. I'm not sure which one. Daunorubicin, perhaps mitoxantrone, or Mylotarg, or both. And keep in mind the biology and CD33 expression, what they have initially, etc. In the setting of a relapsed AML, I certainly would add a targeted agent when that's possible, meaning there's the target and you have drugs. But think about the FLT3 inhibitor, think about the menin inhibitor, think about venetoclax. And all children, I think at the moment, are eligible for a transplantation, even if it's the second one. We might need smaller, smarter, other clinical trials, another trial design, although that's not always accepted by authorities, I should say. So many colleagues, of course, contributed to the slides I showed, listed here. On the right is a picture from the Princess Maxima Center. It's not a drawing or a painting, it's a real picture. And of course our queen gave us her name. She's an ambassador. We decided to maintain the name Princess Maxima Center because the children like it better than the queen, don't they? But also this lady, after some decades, she will be a princess again, because then we will have a next queen, and she will remain to be a princess. So it's on the long term a good name. So thanks for your attention, and I hope you have some questions or topics you want to bring up. Thank you.
Good morning.
Good morning.
I have two questions. One is about the indication of stem cell transplantation in isolated CNS relapses with completely negative MRD at the moment of CNS relapse, because it's difficult for me to think about the anti-leukemic effect in CNS.
Yeah, no, good point. Preparing this talk, I also looked at my own papers, and I had a paper some years ago in British Journal of Hematology, how to treat relapse AML. This case has been described. I think I would go in a way for the safe side, meaning I would assume it's systemic disease. I think that's going for the safe side. But I know there have been case reports published on this type of children that had perhaps truly isolated extramedullary disease, and they did not get systemic treatment at all, and some survived. Although, you know, these are the type of patients that you will publish, so I'm really confident. I'm sure there's a publication bias. That type of patients will be published, and all the children that you did it and it failed will not be published. So I think there's, if you look carefully enough, there's often a sign of disease in the bone marrow. And with the more sophisticated techniques, we more often see it. So even, you know, if you don't see it by morphology, you don't see it by flow, you have a signal by molecular techniques. So I would treat an isolated CNS relapse as if it was a regular, in a way, relapse. I would do chemotherapy and I would do a transplant.
Okay.
And then I'm personally not convinced that you must do cranial irradiation in these children.
Yes, this is.
So I would try to clear the cerebrospinal fluid with triple ITs frequently, and of course, if they do not clear it, you have to start thinking about cranial irradiation.
Okay.
Yeah.
Thank you. And the second one is about a more unusual case: is APL completely resistant to treatment. The patient is FLA negative, mutation FLA negative. He received chemotherapy, and ATRA plus anthracyclines, arsenic trioxide. MRD remains positive by RQ-PCR. He received unrelated bone marrow stem cell transplantation, and MRD is still positive. The question is about, for example, I don't know, I look for new drugs, etc., and I don't know if venetoclax has any role in this case of patients. For example, I don't know. We don't have access to anti-CD33.
Mylotarg.
Gentusumab, sorry.
Yeah. Okay, well, first I would go back. Is this really APL
Yes.
with the ultra-sensitive
Yes.
molecular aberration? Because what you describe is extremely rare.
Yes.
And I know that we have also had false positive. I think if you have done it repeatedly, but so a single positive PCR can be contamination. It can be a laboratory failure.
Yes.
That's why we have recommended that if you do molecular monitoring, for instance, after treatment, and you have a positive signal, it should be repeated and it should be validated in another lab.
Yes.
So check for, is it really ultrasensitive APL? Check for contamination. Oh, and you transplant it as well. I have not seen data on venetoclax in APL. Yeah. I thought I would give you the simple answer: do a transplant, because there are APLs quite.
Yes.
It can be cured with transplantation, certainly, although you don't need it anymore in the majority of cases. I'm not sure if I have a good proposal for this setting. That sounds like a very difficult case. Yeah.
Yes. It's very. I only find some papers about the role of venetoclax, and we check, and of course we check the PML positive, but okay, no, it's not usual. I don't know, but okay. Thank you.
By the way, also think about compliance, right? I mean, we know, of course, I know it from some ALL studies, when some children, when they are supposed to get mercaptopurine. And there was this nice study from the US where they looked whether the box was opened or not, and the majority of times it was not opened at all. So ATRA, of course, you have to swallow.
Yes.
And they may throw it away. So check for compliance.
Okay, thank you very much.
Good morning. I have a question for you. What is your take on chemolite regimens, like vein as a upfront in the setting of relapsed AML, and transplant as soon as possible?
Venetoclax
azacitidine, right?
Yeah. I don't think we have seen enough data to do that as sort of a standard of care approach. It might be interesting to explore it in a clinical trial, but I don't think that for the majority of pediatric AMLs it would be effective, but that's perhaps my own sort of assumption. But I would not do that as standard of care. But it's an interesting, of course, thing to investigate. And I know that there's some children that respond remarkably well to that combination, but with having particular biology, right? I think yesterday we had heard about this case with the UBTF aberration. But I don't think the majority of children would respond quite well to that combination.
Hello, I would like to ask about the isolated testicular relapse with MRD negative bone marrow.
Testicular, you said?
Yes.
Yeah, but in a way the same. So I would argue that if you have the most sophisticated techniques, often you will find disease in the bone marrow as well. And I would go as if it was a systemic disease. Yeah.
Thank you.
Yeah, but some children then you may give over-treatment, and then I guess the excuse might be that you want to cure them at that moment, and it's a risk to consider it's really truly isolated. Yeah, so I would typically go for as if it is systemic disease. Yeah.
You said you would not wait for the second induction block for bone marrow regeneration. Assuming the child is doing well, is there like a minimum interval you'd wait? Or what would you recommend?
Yeah, so that is at initial AML, although you might argue it could also be applied in relapsed AML, but we have not studied that to the best of my knowledge. So to explain first, so we had an old trial, and we is now the NOPO group, the Nordic countries, where they learned that these poor responders did quite poor, all right, on the long term. And then they gave intensified induction, and that was also done in the US a long time ago by one of the study groups, before COG existed. And then outcome became equal. So you could overcome this prognostic adverse impact of an early treatment response by giving the second course as quickly as possible. Well, it will never be before day 22 because that's when you do the bone marrow, so it will never be before 3 weeks or so. No, yeah, we sometimes do it the next day. So we get results that we have more than 5% leukemic cells, and the next day we give the second cycle. Of course, you must look at the child. If the child is in intensive care unit with an overwhelming sepsis, we may not do it typically. But otherwise, yeah, we ignore the blood results. If everything is down to 0, we ignore it, and we give the second cycle. Yeah, yeah, and that's. You need optimal supportive care, of course. You need the best supportive care that is you can imagine. But it's doable then. Yeah. Okay, thank you so much. I'm going to look for coffee.